Rounds with our very own Steve Fuest. And Steve completed his undergraduate degree at Niagara University and then medical school residency, chief residency, and was on faculty at Washington University in St. Louis before joining CU in 2023. He's a clinician educator delivering primary care at the Anschutz Clinic and a docs coach, the Anschutz IM LIC liaison, and director for GIM Grand Rounds. When he's not working, he's busy spending time with his son, doing DIY projects on his house, or watching the Buffalo Bills. And today he's going to be talking to us about updates in atrial fibrillation.
Thanks, Nikki, and thanks everyone for joining. Nikki, I really appreciate you too helping out with moderating to reduce that cognitive load for me, so I'm not having to watch the chat while presenting. I also want to give thanks to Brandon Combs. He invited me to give Grand Rounds about a year ago before I knew I was going to have that role of director for Grand Rounds. And so again, just really appreciate that opportunity to talk on this topic today. And also thanks to everyone who makes Grand Rounds happen in the background. Without further ado, we'll get to it. Updates in atrial fibrillation, what primary care should know. In terms of disclosures, I have no relevant disclosures. I want to specify we may end up talking about wearable devices for atrial fibrillation. I don't have any conflicts there either. All my watch does is tell time. I'm also a primary care doc. I'm not an electrophysiologist. And so my lens, my angle with this presentation today is from that of a primary care doc, not a cardiologist. So ACC/AHA updated their guidelines for AFib about a year and a half ago in 2023. And I think there's a lot of reassurance I want to give that a lot of the fundamentals of AFib are still the same. Normal heart conduction starts on the SA node, goes to the AV node, and that's not what's happening in AFib. That's unchanged. You've got this ectopy, you've got these abnormal rhythms, often at the rate of 200 to 300 beats per minute coming out of the left atrium that can cause dysynchrony between the atrium and the ventricles, can cause patients to have symptoms, and it can increase their risk for thromboembolism, in particular stroke. So again, unchanged, we want to be identifying atrial fibrillation, treating the underlying cause, figuring out a control strategy, whether that's rate or rhythm control, and then evaluating who's most likely to benefit from anticoagulation to reduce that risk of thromboembolism, in particular stroke. There are some of the subtle nuances, though, that are new, that are different, that I want to update you on. And there are a lot of topics that I was trying to choose from. And so instead of me choosing, I decided to let you guys choose. So go ahead, get out your smartphone or log into Pull Everywhere with the QR code and the link at the top there. And it's going to give you not a multiple choice question, but it's going to let you order these in your preference. So there's 5 topics here. The one you want to hear most about, put at the top, second most, second all the way down. The one at the bottom is the one that you'd least excited about learning about. You want to prioritize the least. And I want everyone in the audience to vote. And then I'll go over these topics based on what you select. And so in no particular order, what's up there is what's the sensitivity, specificity of wearables or smartwatches for diagnosing AFib? Should patients be referred for an early rhythm control strategy? Outpatient evaluation of and management of transient AFib after a hospitalization, meaning the AFib occurred during the hospitalization, you're seeing them in clinic. What do you do now? Periprocedural management of DOACs and factor 11, not factor 10, but factor 11 inhibitors for anticoagulation.
Steve, we can't see the QR code or a link.
Really?
Yes.
Oh, no.
We can see the options.
You can see the options. Well, then.
Do you want people to just say it in the chat?
Yeah, you can just say it in the chat then.
We've got some B's. An A. B and A definitely seem to be the most popular.
I agree. A lot of B's, and then, like you said, Nikki, A. Give another few moments here for voting. Some BAC. All right then. And we'll see how much time we end up having. It's certainly possible that we can do um, more than 3 or 4. Maybe we get to 5, but this gives me an idea for what you would like to cover. And so we'll push on ahead. So the learning objectives here are similar to those selections that were just there, and we'll do it based on what you selected. So option number 1, early rhythm control strategy. So here's the question. We'll see if this one does or doesn't work. Can you see the QR code there or no?
Still no, unfortunately.
Oh, that's all right. I'll read it out loud, and you guys can vote in the chat and or really just think about it for yourself. But you diagnose a patient with new atrial fibrillation. They are 80 years old. They have hypertension, diabetes type 2. You start them on rate control. And what else should you be doing? A, refer to cardiology for consideration of rhythm control. B, avoid anticoagulation because they could fall. C, start aspirin by mouth daily to balance stroke risk and bleeding risk. Or D, tell them to stop drinking caffeine. So back in some background information, back in 2002 was the Affirm trial. This was done, I believe, out of the University of Washington, and they were looking at for patients with atrial fibrillation, which strategy, rhythm control or rate control, had better mortality. And they actually found that there was no significant difference between either strategy for the outcome over mortality. Those patients randomized to a rhythm control strategy were more likely to have side effects from their medications as well as be hospitalized. And so this was one of the landmark trials for arguing that rate control can be used as a strategy like rhythm control, even though intuitively this idea of fixing the underlying rhythm problem resonates with a lot of people. The heart's in atrial fibrillation, put the patient back in sinus rhythm and they'll do better. This trial really challenged that way of thinking. One of the limitations of this trial was that patients were at all different stages in the disease course of atrial fibrillation. Some of them were newly diagnosed, some had AFib for years. And so that is what led to this trial back in 2020, an early rhythm control strategy for patients with AFib. The thought process behind this is perhaps early on in the disease course, in that first year, there's more plasticity, for lack of better word, in that myocardium. Perhaps pursuing a rhythm control strategy then will help patients more in the long term rather than pursuing a rhythm control strategy, say 5 or 10 years after someone has been diagnosed. So the patients included in this trial, East AFNet4, were people whose AFib had onset in the last 12 months, and they had to have a cardiovascular risk factor. They had to meet one of these 3 criteria. They had to be 75 years or older, have a prior stroke or TIA, or have 2 or more of these following risk factors: be 65 years or older, female, have heart failure, hypertension, diabetes, heart disease, CKD, or left ventricular hypertrophy. And what they did was randomize patients to either early rhythm control or usual care meaning rate control. And the outcome was a composite looking at cardiovascular death, stroke, or hospitalization for heart failure or acute coronary syndrome. In this trial, the average age was 70, about 50-50 male, female. The median onset of AFib at time of enrollment was 36 days, so a month and change, a month and a week. Mean CHADS VAS score was 3.5, and the majority, 90%, were on anticoagulation. This is a zoomed out diagram showing what treatments patients were initially randomized to in each group, excuse me, what treatment patients received in each group after they had been randomized, and where they were at 2 years. And I'm going to zoom in so we can see this better. This trial had a total of about 2,800 patients. This is the half of patients randomized to rhythm control. Importantly, when patients were randomized to rhythm control, the select medication or ablation strategy was left to the treating cardiologist. And so that's why you see this diversity here in the medication selected. Majority were receiving flecainide or amiodarone, and a high number getting ablations as well. You can see at 2 years what strategy the patients were receiving at the 2-year mark. Patients were monitored for sinus rhythm with twice weekly ECGs, as well as if they had breakthrough symptoms concerning for AFib, they could get as needed ECGs as well. This is a diagram showing those patients randomized to rate control. Patients stayed on rate control as long as they were able to maintain adequate rate. Patients could switch from the rate control arm over to I shouldn't say switch from the arm, they could switch from a rate control treatment over to a rhythm control treatment if they were still having symptoms of AFib despite maximally tolerated medication dose. Here's the outcome. And this trial was stopped early after 75% of events had occurred. So it was stopped after about 5 years because of superiority of that rhythm control strategy. So the hazard ratio was 0.79, again, superior for early rhythm control compared to usual care. And importantly, it was well distributed among the individual components of that composite. So it's not as if one of those events was the main driver here. It was fairly equal amongst cardiovascular death, stroke, or hospitalization for cardiovascular cause. That primary outcome, again, occurred in 3.9% of patients in the rhythm control strategy and 5% in the usual care arm. And so this comes out to be a number needed to treat of about 90, meaning you have to do early rhythm control for 90 patients to prevent one of those composites over a 5-year period. One of the limitations of AFFIRM was that, I shouldn't say limitations, one of the key findings in AFFIRM was that patients randomized to an early a rhythm control strategy were more likely to be hospitalized and have medication side effects. In this trial here that I'm describing, patients were not more likely to experience hospitalization. They were more likely to have medication side effects though. So going back to this question here, what should you do for this patient? This is someone that I would refer to cardiology for consideration of rhythm control. The reason is that they meet criteria for this trial. They're over 75. Even if they were younger, they have 2 risk factors, hypertension, type 2 diabetes, 3 risk factors, and are older than 65. I would not avoid anticoagulation. There's retrospective analyses that suggest in order for the risk of falling to outweigh the benefit of anticoagulation, the risk of falls leading to intracranial bleeds, outweighing the stroke risk reduction with anticoagulation. So one have to fall an average about once a week, so a very high frequency. Aspirin, 81 milligrams, does not lower stroke risk nearly as much as anticoagulation, and bleeding risk between aspirin and DOACs is very similar. So treating with aspirin is less benefit with the same amount of potential harm. And drinking caffeine, that is something that's not a blanket recommendation. If patients note that drinking caffeine does seem to precipitate atrial fibrillation symptoms, in that scenario, absolutely can advise reduction or cessation of caffeine, but complete cessation of caffeine for all comers is no longer recommended. So next most popular was patient-worn devices. So your patient sends you a My Health Connection message stating their watch tells them they had an episode of AFib and it's now over. What do? Refer them to cardiology, bring them in for a visit in a 12-lead ECG, provide reassurance the watch is unreliable, or D, start rate control and evaluate for anticoagulation treatment. The answer B is coming up right now in the chat. And so, and also asking for screenshots of looking at what the watch is telling them. So let's see what the evidence says here. So first and foremost, wearable devices, how do they even work with detecting heart rhythm? There's two main technologies that are doing this. One is using photoplethysmography. Don't ask me to say that again. It's the same technology that a pulse ox is using on the tip of a finger. So it's using LEDs and lights and reflection back to detect blood flow. That is something that's on the back of the watch. That is one method that's continuously going when individuals are wearing a wearable device such as a smartwatch. The other way is getting a single lead ECG. And the way that's done is the watch itself is one of the leads, typically on the left upper extremity, though certainly could be worn on the right wrist as well. And the opposite extremity typically is going to touch the crown. This is the dial that usually would be used to turn to adjust the time. But by having a finger or two from the other hand touch that, you can get that single lead ECG. Importantly, these are FDA cleared devices, not FDA approved. There's a different process through the FDA for clearance for medical devices that is relatively less rigorous than FDA approval for a medication. So these devices have FDA clearance, and that's going to be important, as I'll mention in a few slides here. Most of these devices have one of three results: a normal sinus rhythm, atrial fibrillation, or inconclusive. When these devices are sent for FDA clearance, each individual company has their own population that they tested on. Historically, these have been younger, healthier populations with lower baseline rates of atrial fibrillation. Additionally, when these companies are calculating and presenting their sensitivity and specificity, they're removing that result of inconclusive. So they're calculating sensitivity and specificity of their devices compared to a 12-lead ECG, just looking at the results of normal sinus rhythm and atrial fibrillation. So many of these are reporting sensitivity specificities in the high 90%. And there's really different studies out there looking at how well these smartwatches function or wearable devices function. It's not that this is the one and only. I really liked this paper because it compared 5 of them. And I also really like the way that they designed it. So this was a single center study out of Switzerland. And essentially what they did was they took patients who were already at the hospital for a scheduled elective procedure, whether that was a catheter ablation, cardioversion, or device placement. They took these patients who were sitting there in the pre-procedure area. They all needed a 12-lead ECG before they got the procedure anyways. And so while the patients were waiting to get this done, they had them put on 5 different devices and get a single lead ECG. And then they compared the what the device said about that single lead ECG to the cardiologist interpreted 12 lead ECG. So the patients who are here are different than what a lot of these companies use for their FDA clearance. So you can see average age is in the 60s or 70s, 81% had atrial fibrillation. Most of them were going in for a pulmonary vein isolation for AFib. Here's the results that they found with all these different devices. You can see there's Apple Watch, Samsung Galaxy Watch, the Withings Scan Watch, Fitbit, and KardioMobile. And I'm gonna block out all but one device at a time so you can see what the results are and we can focus in on that. And again, I want to emphasize that most of these devices report sensitivity specificity in the high 90s. In this study, though, the sensitivity specificity included those inconclusive readings. So we're not on Apple Watch 6 anymore, but that's what it was at the time of the study. You can see sensitivity, 85%, specificity, 75%, 18% of tracings were inconclusive. Fairly similar results here for the Samsung Galaxy Watch for sensitivity, specificity, and how many tracings were inconclusive. I truthfully have not seen the specific watch as much in my clinical practice. Its claim to fame is that it's the only analog smartwatch. And so within ScanWatch, sensitivity, 58%, specificity, 75%, inconclusive, 24% of the time. Fitbit, 66, 79, and 21. And then KardioMobile, which is not actually a watch, it's a device. You can see there's those two silver squares on there. This is solely for ECGs. And so patients are able to put fingers from opposite extremities on there to get the single lead ECG. Sensitivity, specificity, inconclusive, all listed right there. So this study found that 17 to 26% of those single lead ECGs were inconclusive by the device algorithm. When the cardiologist interpreted these ECGs, cardiologists looked at the single lead ECG, only 1% were inconclusive, meaning when a doctor actually looks at this, instead of 17 to 26% being inconclusive, it's just 1%. The reason for this most commonly was of tachycardia or bradycardia. So the algorithms of these devices are limited in that they're only able to diagnose sinus rhythm or atrial fibrillation, typically between 50 to 100 beats per minute. Apple Watch can now go from 50 to 150 beats per minute. But this is really a significant or a major limitation here. I'll show you example tracings that the device is read as inconclusive. And you can see what it is compared to the 12 lead, and you can also see the single lead. So 12 leads on the left, single lead is on the right. This one was for the Apple Watch, and the device reported this was inconclusive. I'm not sure that I could fully say that this is AFib, or AFib or A-flutter. I look at that and it looks irregularly irregular to me in that single lead. So for me, as a clinician, when I look at that, I don't say inconclusive, I'm not sure. I say there's something going on here. There's an abnormal rhythm. This is looking at Fitbit. The 12 lead showed sinus bradycardia. Fitbit said inconclusive, low heart rate. I say, gosh, that is really going slow. So again, I think inconclusive is inadequate here. This is something where the device is not as good as a clinician. And I alluded to this before, but this study was done in 21 to 22. And so all these devices that were studied are prior models. And this is a little bit of a circular argument here. The manufacturers can likely argue that, well, that was 2 or 3 algorithms ago. We're better now. We're better now. I have some hesitancy there. So for this question, the patient sends you a message stating their watch tells them they had an episode of AFib and now it's over. What do you do? Personally, I would be bringing them in for a visit in a 12-lead ECG. I'd want to be getting more history, figuring out, reassessing exactly what are their risk factors, see what rhythm they're in on that 12-lead ECG, acknowledging that's a 10-second cross-sectional piece of data. I'd also want to look at the rhythm that was on their device if the patient's able to produce that. And depending how concerned I am or not, reassured I am or I'm not, potentially doing a 14-day monitor. I don't think that we can just say this device is unreliable, ignore it. I do think that it is potentially premature to start the patient on rate control if this was one single brief episode that we have not yet confirmed. Next, I will go to post-hospitalization AFib. So you are seeing a patient in clinic for a post-hospital visit after they were hospitalized for pneumonia. While they were admitted, they had 15 minutes of AFib with spontaneous return to sinus rhythm. What do you do now about that episode of AFib? A, refer them to cardiology. B, do nothing. It was provoked. C, start rate control and determine if they should receive anticoagulation. Or D, do outpatient monitoring for AFib recurrence. So when I was in medical school and really early in residency, the teaching was that secondary provoked AFib was a free pass. It was due to the illness. It was not something that necessarily needed specific treatment if it had ended. And the thought process and thinking on this has really shifted over the last several years. There's a lot of retrospective studies on this that I'll present to you. For those patients who, I'll call it secondary AFib, meaning they have an underlying precipitant, whether it's sepsis or a different infection, surgery, those patients have a recurrence at 5 years, 41% of them will. 41% of those patients are going to have AFib again sometime over those next 5 years. And we know those patients who have recurrence from a secondary cause have worse outcomes. They are at increased risk for stroke. They are at increased risk for death. And those are bad things. We certainly want to avoid them. The question is, what do we do to best identify those at risk, and how do we then help those patients the most? There's a few different trials that I'll present. They're smaller, lower quality or smaller size trials that I use to try to help piece this evidence all together. This is one that was in Annals about 2-3 years ago that was looking at patients with transient new AFib during their hospitalization. They matched those patients hospitalized who had transient or provoked AFib to other patients hospitalized that same time who did not have AFib. And they followed them up with 14-day monitor, both 1 month at discharge and 6 months at discharge. And their outcome was looking to see who had documented AFib. Patients had symptoms of AFib, they could also get assessed at that point. And at 12 months, those who had AFib during hospitalization, a third of them had a recurrent episode of AFib. Those who had no AFib during their hospitalization, 5% of them did. And these were not short episodes either. The median length was 8 hours. So again, more evidence here. This one was a prospective study, not a retrospective, that AFib that happens during hospitalization that's provoked by something else is actually probably suggesting that there's sick underlying myocardium predisposed to it again in the future. So what do we do to help these people out? There's been one study that certainly has limitations. It was out of the VA. They looked to see for these patients if they were followed by their primary or they referred to cardiology, what were their outcomes? And there were small but real lower risk of stroke and mortality for those who saw cardiology. Now, that's the key word there, is those who saw that in order to see your cardiologist, you have to have one in the area. You have to have transportation, the means to be able to get on in. And so this study in its retrospective nature may not have fully accounted for all of those confounders that also lead to patient outcomes. And again, I said this before that there's retrospective studies suggesting the thromboembolic event rates similar if AFib is primary or secondary. But we don't have those prospective studies yet that are telling us what is that optimal treatment. Is it to anticoagulate them? Is it to do rate control? Something else? Is there a way to risk stratify them? I am hopeful that this trial will give us some answers. It's ongoing right now. It's a blinded RCT looking at 100 patients who have post-op AFib after a non-cardiac surgery, who then spontaneously return to a normal sinus rhythm. And they're randomizing them to either a DOAC or a placebo and going to see, is there a difference at 2 years for stroke or systemic embolism? So I'm curious and awaiting to see if Aspire AF will give us some more clues and answers here. So for this question of your senior patient post-hospital after pneumonia, they had provoked AFib while they were admitted, what do you do? Personally, I would do outpatient monitoring for recurrence. The exact frequency is not defined. This is really more of the art than the science here. But I do think doing some 14-day monitors with as needed evaluation for symptoms is very reasonable. You could, I think, also make an argument for referring to cardiology because we don't have those prospective studies showing benefit for patient outcomes with monitoring. You could also, I think, argue do nothing until the patient has symptoms. C, starting rate control, determining if they should receive anticoagulation. At this point, I think it's likely premature to do that. There is one exception that I want to mention about provoked or secondary AFib to really emphasize here. The one cause of secondary AFib that does not have those worse outcomes of stroke or mortality is hyperthyroidism. Specifically, what I mean is if the patient has hyperthyroidism and that's the cause of their transient AFib, and you treat the hyperthyroidism, that future risk there for AFib is reduced. It's not the same as someone who has primary AFib. So if I have a patient whose AFib is happening in the setting of hyperthyroidism, I would be less likely to monitor or consider specific treatment for them. Next, well, we'll go to the periprocedural DOAC holding and restarting here. So the question for you guys is, when should anti-10A anticoagulation be held before an elective procedure or surgery? Do not stop. Continue the anticoagulation throughout. Stop it 1 to 2 days in advance. Stop it the day of the procedure. And alternatively, check an anti-10A level. And when you stop the medication depends on that. So I'm going to give some background here for this question too. Back in 2015 was the bridge trial. This was looking at periprocedural anticoagulation for patients who were anticoagulated with warfarin, not with the DOAC, but with warfarin. The summary of this is those patients who received bridging anticoagulation with dalteparin had the same rate of systemic thromboembolism as those patients with no bridge. However, those patients who received a bridge had higher bleeding rates. And so for those patients anticoagulated on warfarin, this really set the standard for not bridging except in very unique circumstances, such as metallic valves or APLS or recent clot. But what do we do with the DOACs? The DOACs certainly work differently, and the timing to stop them without a bridge was not really clear. There was not one set standard way. And so rather than the bridge trial, there was the pause trial. And this took a different approach. It essentially said rather than randomizing patients to different treatments and seeing how they do, they said, well, we already know what an acceptable bleeding rate is with these procedures with patients on anticoagulation. We already know what an acceptable thromboembolism rate is, stroke rate is. And so rather than comparing two groups, we're going to assign everyone to the same treatment strategy and see how well those strategies work. They had about 3,000 patients. They had about half of them on apixaban, a third on dabigatran, a third on rivaroxaban. I'm going to present just the information for rivaroxaban and apixaban because those are the ones that we use most often. And they had a set schedule for when to hold these medications because they have predictable half-lives. And so if you stop at 5 half-lives in advance, then the medication should be completely out of the system. And so here's the schedule for when to stop these meds and when to resume them. They broke them down into two different groups, high bleeding risk with the procedure or surgery and low bleeding risk. And so what's high bleeding risk? It's procedures that had neuroaxial or epidural anesthesia, neurosurgery, cardiothoracic surgery, open, not laparoscopic, but open abdominal surgery, vascular surgeries, or total joint replacements. And so for those surgeries with high bleeding risk, the DOAC was stopped pre-op day 2. So that would give 5 half-lives for it to be fully out of the system by the day of surgery. And then the DOAC was resumed post-operatively on day 2 or 3 at the discretion of the treating team based on how likely they thought the patient was to bleed or have an issue with bleeding with resumption. The low bleeding risk procedures, these are things like endoscopy, skin biopsy, cataract, pacemaker, defibrillator replacement. These had the DOAC stopped pre-op day 1, so there'd be 3 half-lives. So there'd still be a little bit of DOAC in there, but mostly gone in the blood. And then resuming the DOAC post-op day 1. Again, trying to strike that balance of post-op or perioperative procedural bleeding with systemic thromboembolism stroke. And I'll compare and contrast actually some of those rates here for the pause trial, this DOAC trial with the bridge trial. So for their 30-day bleeding rate, it was 1.35%, 1.85% for apixaban and rivaroxaban respectively. And you can see how that compares to the no bridge group in the bridge trial, which was 1.3%. So fairly similar, and this was in the acceptable range on the trial parameters. The 30-day rate of arterial thromboembolism, 0.16%, 0.37% for those two DOACs. And gosh, that's similar or even lower than what was seen in the bridge trial. And so this is really some of the strongest evidence, this meaning the pause trial, for a standardized schedule for how to treat patients who have AFib, they're getting a procedure done, and what do we do with not warfarin, but a direct oral anticoagulant. So for this question, the answer would be 1 or 2 days, depending on what the procedure is and how high risk it is for bleeding. The final topic is going to be factor 11 inhibition. So we had a variety of anticoagulants for AFib. These are not yet out on the market, but I'm curious and interested to see if they will be in the upcoming years. And so I want to give that sneak peek here. So taking a step back, what are we doing with anticoagulation for AFib? Again, we're trying to reduce that risk of bad outcomes, strokes from happening. But we do that with the caveat of bleeding risk can increase. So if you thought you were done seeing the coagulation cascade, well, it's not too late. Here we are today. I'm not going to go into too much nitty-gritty detail. This is really to highlight some key concepts as well as where different anticoagulants are working. So blue, those letters and boxes in blue, that's the common pathway that both the extrinsic and intrinsic pathways converge on. Red is the extrinsic pathway. That's what's important for hemostasis. So if there's injury, the body needs to stop bleeding. Hemostasis is actually what we want. If the head gets hit, if there's an issue in the GI tract, you want that bleeding to be able to stop. Green is the intrinsic pathway. That's what inflammation, luminal injury are going to result in thrombosis or clot formation. That's what we don't want to happen with atrial fibrillation. So warfarin, where does it work? It's on factors 10, 9, 7, and 2. And you can see that it's a variety of locations in all of these three pathways. Dabigatran is a direct thrombin inhibitor, which also impacts some different cofactors and other portions of the coagulation cascade. So again, that common pathway is being impacted. So both hemostasis and thrombosis. Apixaban, edoxaban, rivaroxaban, 10A inhibitors. And so those are going to be impacting the common pathway. So both hemostasis and thrombosis. Well, factor 11, it sits up here. So it sits just in the intrinsic pathway, primarily impacting thrombosis. And the idea behind factor 11 inhibition actually comes from epidemiologic studies. And so there are people who are born with deficiencies in factor 11. Those individuals have reduced rates of venous thromboembolism and stroke compared to the general population, but they do not have increased rates of spontaneous bleed. Conversely, people born with elevated levels of factor 11 are twice as likely as the general population to have a venous thromboembolism. And so conceptually, based on some of those epidemiologic studies, it seems like factor 11 is a really good target here. Maybe we can thread that needle with factor 11 inhibition to prevent strokes without increasing rates of bleeding. And so there's a lot of ongoing studies for this. There's actually one of these medications that's been studied for venous thromboembolism prophylaxis after knee replacement that has been shown to be efficacious there. There's multiple stage 2 studies as well for AFib. Some of those have shown lower rates of bleeding compared to anti-10A inhibitors. The issue with these studies at this point is the factor 11 studies have either shown higher rates of stroke compared to 10A inhibitors or just have not yet been studied. So we really need more studies showing how the benefit of these meds compares to 10A inhibitors before we can start thinking about using these for prime time. So I want to be clear, factor 11 inhibition is not used in clinical practice yet. Maybe it will in the future. Maybe that's coming up in the next 5 or 10 years. Maybe not. Maybe this is something that conceptually was very hopeful and promising, but clinically we're not able to identify an agent for it. But again, it would be really wonderful if we could thread that needle, reduce the risk of stroke for patients with AFib without increasing risk of bleeding. So I have many references here. I want to go to my conclusions and then go to the Q&A. So if you guys have questions, please start thinking of them, typing them into the chat, and you can do that during the Q&A. But my conclusions are for those wearable devices, trust them, but verify. Really looking at that single lead ECG the device is creating yourself. Don't trust an inconclusive rhythm though. These devices seem to be good for normal sinus rhythm and AFib, but if it says inconclusive, it could be something that's very clinically relevant. For rhythm control, there's a select group of patients that we do know there's benefit for pursuing an early rhythm control. Again, those patients with new AFib in the first 12 months. Secondary provoked AFib, it's not benign, and we're still working to figure out what is that optimal follow-up. For patients on apixaban, rivaroxaban, those meds typically should be held 1 to 2 days in advance of a procedure, depending on that bleeding risk of the procedure. And then factor 11 inhibition is exciting, ongoing focus of study, but not yet ready for prime time. Thank you, guys. And I see there's already some questions coming on in the chat. So the first question I see is from Annie. Any thoughts on patients with AFib and liver disease, fatty liver and early cirrhosis who may have some degree of auto anticoagulation? So the liver dysfunction is, truthfully, it can be very tricky for the reason that you said there, Annie. So those patients can be at increased bleeding risk, but depending on the specific factors that are deficient, those patients can also be higher risk for clots. Part of it, the treatment approach to those patients, I think, should be based on what is their history. So if they've had a history of significant bleeds or they've had a history of significant clotting, treating to prevent one versus the other. The other thing I think about is thromboelastography, so TAG, ROTEM, and seeing if that could be utilized to help identify what those patients have excess of and what those patients are deficient in to help balance their coagulation, thrombosis, and hemostasis profiles. Michelle asked, what was the rate of wearables saying AFib, but it's not AFib? False positives there. I would have to, I'm not 100% trying to reverse calculate that. I would think it's going to be in the low single digits based on the initial sensitivity specificity that these companies put out for those devices. So my guess is it's probably in the single digits. I'd have to get back to you to confirm though. Brandon asks, can you suggest who benefits most from rhythm strategy and who benefits comparatively less, since East AFNet4 enthusiasm from rhythm-based strategy has increased substantially, which has been hard to reconcile with a small benefit on average with this approach? Yeah, so I think you're really hitting the nail on the head there, Brandon. And I've got a few comments on that because there's some things that are, I think, conflicting with the guidance on this. And what I mean by that is those patients who are most likely to benefit probably are those with relatively increased cardiovascular disease. So thinking of some subpopulations, patients with HFrEF, there's been other studies that have shown those patients absolutely benefit, not just from early rhythm control strategy, but specifically early ablation. So patients with HFrEF who are symptomatic with their HFrEF, we seriously should be considering not just rhythm control strategy, but ablation for them. The East AFNet trial was looking specifically for those patients with those 3 criteria, one of which was age 75 or older. The risk factors were one of those risk factors too, where you had to meet at least 2 or more, was age 65 or older. And so that trial would suggest that patients with increasing age, we should be considering this. Conversely, if you go to other parts of guidelines, they would be recommending younger patients too, thinking about lifetime burden for AFib, considering those patients for rhythm control strategy. And so I think to an extent, the jury is still out on this, and we need to fully narrow down who's most likely to benefit, because treating 91 patients with a rhythm control strategy to prevent one death, hospitalization, one of those events. Those are important outcomes, but that is a high number. And so how do we prognosticate? How do we personalize to these patients to figure out who's most likely to benefit? Another comment I'll make on this is after East AFNet came out, there were retrospective analyses of AFFIRM. AFFIRM was that original trial back in 2002 that showed no mortality difference between rate control and rhythm control. Those retrospective studies of AFFIRM were trying to figure out, well, what happens if we break AFFIRM down and just look at the subset of patients with AFib newly diagnosed in the last year? So the same patients who would have been included in East AFNet. And when you do that with the AFFIRM trial, the outcomes for patients in AFFIRM are the same, meaning in that AFFIRM population, there was not a mortality benefit with rhythm control strategy compared to rate control for those with newly diagnosed AFib. The reason that's been postulated to try to explain that is essentially our rhythm control strategies are now better. AFFIRM did not use ablation. That was not one of the options for rate control. Excuse me, for rhythm control. Ablation was not used in AFFIRM. And the pharmacologic methods were different. There was a lot more amiodarone and I believe propafenone compared to East AFNet used flecainide, which tends to have less side effects compared to other antiarrhythmics. So that is a piece of data I just gave you guys. I think it leads to more questions about, well, what is it with these strategies? What is the best rhythm control strategy for using, as well as, again, what are the specific patients, their underlying characteristics and predictors, so we can be even more specific with early rhythm control.
Well, Steve, this was awesome and really high yield. A good review in an area that's kind of very rapidly changing. My own concern always about this is with the rate versus rhythm control. I feel like it's so nuanced at this point that almost everyone warrants a cardiology evaluation, at least to consider. And that's a lot of cardiology evaluations and something that previously could be pretty well managed by primary care.
I agree. I think there's a resource allocation issue and also need to be very cognizant of, I mean, we're fortunate we're at an academic center where we have many cardiologists, but for people in different geographic locations around the country that they may not have that resource. And so that may be an avenue where some telemedicine becomes more beneficial, or the e-consult relationship. And I do want to specify too, me referring someone for an early rhythm control strategy, I'm not going to sit there and not start a rate control strategy and be considering anticoagulation before I do that. I'm certainly still going to be doing that initial management, looking for secondary causes, ordering an echo, etc.
Mm-hmm. Well, this was fantastic. Thank you so much.
Yeah, thanks everyone for joining, and thanks for working with me through the poll everywhere concerns or issues.
Take it easy.